On this episode of the ASC Podcast with John Goehle, we discuss the latest news in the ASC industry, including updates on supply chain disruptions, a discussion of how employees can ease the transition from the hospital to the ASC setting, and in our focus segment, we'll do a deep dive into the OAS-CAHPS and the pending implementation in January 2025.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com.
Welcome to episode 232 of the ASC Podcast with John Goehle for October 19th, 2024, recording from our portable studios in Hilton Head, South Carolina. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and Operations Manager for Ambulatory Healthcare Strategies. We'd like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it is important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by their relevant regulatory bodies. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
So I don't know if our listeners can hear the ocean in the background and the birds outside of our window here, but indeed we are in Hilton Head, South Carolina, and we come down here quite frequently, actually. And I know if you're a long-term listener, you've heard several or many episodes over the years from down here. But we've had a beautiful week, absolutely beautiful week down here. Getting some relaxation, but the work world still interferes in our during our trip here. But
yeah, it does. But great. We went to a dolphin. Not really cruise. It wasn't a huge boat, but it was so much fun yesterday. We did that, and we've had a lot of good seafood and
that's right,
enjoying ourselves.
Which we have a hard time getting good seafood when we're landlocked up in upstate New York. But it has been great down here, and we are recording on our last full day here. Tomorrow we'll start heading back to Rochester. It's been a pretty interesting couple weeks since our last recording. Sue and I, on our way down to Hilton Head, visited our new center outside of Richmond, Virginia. It's called the West Creek Endoscopy Center, and we were there for their first day of operations, which was fun. It was a long day, though. They scheduled 12 cases, and they got them in, but it did take a while to do that. But there was a lot going on, and great group of people down there, and we really enjoyed our stay with them and wish them the best of luck as they get ready for their Medicare certification survey. So they started operations, but as many of you know, in order to get your Medicare certification, you have to do a certain number of cases before you can even apply for that certification. And then our Empire Ambulatory Surgery Center in Staten Island is about to open this month. They just went through their state survey, did very well. So they're just getting all the last-minute stuff done before they open. Very proud of that center also. The first freestanding ambulatory surgery center in Staten Island. So that's unfortunately, Sue, you and I will probably not be able to visit them on their first day of operations, but we're not even sure when that date's going to be yet. And then as we're heading back to Rochester, or we live outside of Rochester, we're going to be starting up our October cohort of the Director of Nursing Bootcamp, which will start on Tuesday. So depending upon when we were able to publish this episode, hopefully it'll be before that date. The Director of Nursing Bootcamp is our most popular. Our Administrator Bootcamp is popular too, but the number of attendees for the DON Bootcamp are usually more than for the Administrators Bootcamp. And that it is a 4-day virtual conference. For those that are not familiar with our bootcamps, they are the most popular leadership training program in the ASC industry by far. I mean, there's nobody that comes even close. We have over 350 graduates over the last 4 years, and all three of our boot camps have a very similar style, and that is it includes a 4-day virtual conference that is recorded and made available to the listeners or to the attendees, for usually between 6 months and a year afterwards, though it usually is actually longer than that. It includes 1-year membership in the ASC-Central, which is our membership website, and it includes all kinds of resources like policies and procedures, state regulations, forms and checklists, example board and committee agendas, and example fire and disaster drills. And probably one of the most popular additions is the mentoring portion of the boot camp, and that is the ability to drop in on a weekly basis, usually weekly. We haven't done it for the last 2 weeks here as we've been on vacation, but we do usually have a drop-in session about 10 o'clock on Eastern Daylight Time or Eastern Standard Time, depending on the time of year, on Saturdays, where we invite everybody by Zoom that's a boot camp member or patron member to ask any questions that they might have or just share some experiences. And it's been a lot of fun over the last 4 years as we've done these drop-in sessions. So again, all of those are included with the cost of the boot camps. Now, the Director of Nursing Boot Camp is generally in October and May of each year, and the Administrator's Boot Camp is generally in January or July of each year. The Business Office Manager Boot Camp is on-demand only, and there are on-demand versions of all of these programs, which means that you can start up at any time. So if you want more information about these boot camps, it's available at ASC-Central.com. Again, a great way for experienced administrators, directors of nursing, and business office managers to really prepare themselves for their job or to do better at their job. And I think many of the people that sign up for them are new to their roles. And this is a great way of kind of introducing them to their responsibilities. It's also a great way to get AEU credits if you're CASC certified. Because each of the boot camps offers 28 AEU credits. So that's quite a bit of credit for attending this conference. And again, remember, if you can't attend virtually, you do get access to the recordings. In fact, Sue, we do have people that sign up for the boot camp and end up not being able to go at all. And they end up with the recording afterwards. So
or
again,
you can pop in here and there. That way you can ask a question if you want, but then you can always follow up with the recording.
Right.
And of course, if questions come up during the recording, as John mentioned, we have our drop-in sessions.
Yeah.
So you can always just pop in and ask a question there.
Those drop-in sessions are very popular. We do periodically do them not on Saturdays. We've done it on Mondays. We've done it on Fridays. We tend to try to keep it as close to the weekend as possible because midweek is very difficult with our schedules. But again, ASC-Central.com for more information. I do want to point out that this is a special episode that is sponsored by Surgical Information Systems, one of our sponsors. And I do want to thank all of our sponsors of the podcast for their ongoing support. They really help us to afford the cost of this podcast, as well as giving us a lot of resources and giving us a lot of great input, primarily in the form of interviews. We do want to welcome our newest sponsor, which is RFX Solutions. We're working with RFX to schedule their first interview. But again, a wonderful organization if you're not familiar with them, and definitely visit our website at ASCPodcast.com to get a link to them. But this episode is sponsored by Surgical Information Systems, and we're going to do an interview with Lindsay Hanrahan about OAS-CAHPS. Sue, it seems like we just keep talking about it, but I'm really worried that people are falling behind and getting ready for the implementation in January. And you really don't want to wait too long to sign up for it. We're already finding people that are having problems finding an organization to be able to do OAS-CAHPS through. And we know that some of them are dropping out right now. In other words, they're not able to take on any more people because of the vast number. I mean, 6,000 surgery centers are going to be signing up for doing this OAS-CAHPS. So I won't go into any details right now because during our second segment, we're going to do a real deep dive into that. Sue, let's talk about some of the news. And of course, the big thing that we've been talking about for quite a number of our recent episodes is supply chain issues. And I know most of our news today are related to supply chain.
Yes, it is. So from HIDA Clips, John, you get those emails from HIDA, and we find a lot of useful information.
Yeah, HIDA is the Health Industry Distributors Association. I work with them quite a bit, helping their distributors to know about the industry, and I'm very grateful for the organization for giving me their weekly news clips.
So they had some information on the strike that we had been talking about. They have reached a tentative agreement. So the International Longshoremen's Association and the U.S. Maritime Alliance reached a tentative agreement, and the port workers have agreed to return to work after a short strike. The workers received a pay boost, and the tentative agreement will last until January 15th, 2025. So they're going to continue negotiations, and hopefully they'll be able to come to a permanent solution.
Yeah, and the biggest issues there were they were looking for a very large increase in pay, as well as curtailment of automation.
Yes.
And I know the automation issue is a big deal because automation is extremely important for efficiency in these ports, and I think the longshoremen are really trying to save the jobs that could potentially be lost if more automation occurs. So, we've got a little bit of a reprieve here until January, but we'll keep an eye on the negotiations there, and hopefully things will be resolved before it becomes a problem again in January.
Yep. And just as you're following this, I wanted to mention the Association of Healthcare Value Analysis Professionals, or AVAP or AHVAP, in partnership with AORN and AVA, which is the Association for Vascular Access, developed an Emergent Supply Chain Disruption Resource Center. It includes information on the supply of IV fluids due to the closing of Baxter manufacturing facility in North Carolina, which was caused by the effects of Hurricane Helene. While this issue is being addressed, they had suggestions for conserving the current supply, and these included prioritizing oral hydration when possible and appropriate, use of alternative routes of medication administration when appropriate, such as oral, sub-Q, or intramuscular, and that's something you can probably get some information from your pharmacy consultant if you're looking to make changes. They also provided links to resources on alternative IV and irrigation solutions and a link to the Baxter webpage for updates and the FDA list of drug shortages. The supply chain disruption resource also addressed the recent port workers strike. As we mentioned, this is currently, at least temporarily, resolved, but it's going to be a good place to check if other supply chain issues came up. I think it's going to be a good thing to keep bookmarked and checking periodically.
And of course, we've been talking about supply chain, since even before the pandemic.
Yeah.
So I think you really, as an administrative director of nursing, need to keep your board totally up to date on what's going on here, because we've already heard about surgery centers that have had to shut down or curtail the number of procedures they're doing, or reduce the number of complex procedures that they're doing, and this could really have a serious implications for our organizations out there. We'll provide a link to the resources that Sue just mentioned.
From AORN Periop today from August 26, 24, they talked about some tips for moving from the hospital to the ASC. It was titled Hospital to ASC, How to Make the Move, some information and tips from Jan Davidson, who is the board chair at HHC. So some of the benefits that you mentioned were the accommodating schedule, often no nights or weekends. Possibly you could be per diem now. Of course, that is changing.
Yeah.
Some places are open on weekends, but much less so than the hospital shifts would be. Expanding your skill set. You can delve into the particular specialty to really hone your skills. You may also care for patients both pre and post-operatively. So that is a good point. You're really delving into the care of the patient, often right straight through.
Right. You're not getting so specialized as you often are in the hospital environment.
But you are specializing possibly in one procedure, depending on
Right.
if it's a multi-specialty place where you go to or not, where you'd really see a lot of it and really be able to, as I said, kind of a deep dive into that. Deeper connections with other team members. And you hear that a lot,
Yeah.
that really you get to work with the same people and you're all working toward that same goal of giving the best care you can. And you see the direct results of that because it's a smaller environment.
Right. And almost everybody will be able to see the patient
Yes.
leave,
Yeah.
the facility, whereas that might not happen in a hospital environment.
And some things to be aware of. You'll need to take on multiple roles, like, working with QAPI, infection control laser, or radiation safety officer, which can be a plus for some people that really just want to, have a bit more ownership. But,
Yeah.
you do have to be that type of person that can be flexible and doesn't mind expanding your role. You may need to be more proactive in keeping up certifications and education. You're not as likely to have a dedicated educator. So, you may have to take on a bit more responsibility with that. And ask yourself if you have these skills. The ability to handle fast turnovers. Like John has mentioned, this is not a place to go if you just want to kind of sit back and have an easy
Right,
time of it.
right.
It is a fast-paced environment. Specialty expertise. And are you comfortable collaborating with surgeons? Because I know that they're in the hospital often, there's a bit more of a barrier between you and the doctors.
Right.
So in this case, you hopefully are comfortable speaking up and making sure that you're protecting the patient and that, it's kind of nice, though, to have that role where you can really collaborate with other people in your workspace.
Yeah, I think it is important. First of all, we need employees, nurses, techs, everybody, coming from the hospital into the ASC industry as we continue to grow, as we continue to see a migration of cases into the ASC setting. So it is important that we look to recruiting people from the hospitals as well as getting to, all of these employees directly out of school. It never used to be that way. We always had to recruit from the hospital, but the world is changing, and we're now starting to realize that, that this could be a career path. In other words, that, like Sue, you started out after your education going right into the hospital, as did Jenna, my daughter. But that's not the career path for everybody now.
Yeah.
And I think that's going to be an ongoing change in the way people are moving, coming out of school. So definitely, I thought this was a good article. Again, we'll provide a link to that article so that you can see for yourself and pass it on to your colleagues out there in the hospital industry. It's important for us to try to recruit them, but it's also important for us to make it very clear what the differences are between a hospital setting and the ASC setting.
Yeah, you just want to end up with a good fit.
That's right. Absolutely. It's not going to be the right fit for everybody, by the way.
No.
So, Sue, we've been dealing quite a bit over the last couple of weeks with many of our centers. We have 87 centers in, 16 states, I think. And this seems to be a universal problem, though there are some hot spots, like we know in Western New York, for example, there's quite a severe shortage. I'm not quite sure why that particular part of the country is dealing with those major issues. But the IV fluid shortage was caused by the closure of the Baxter plant, which was right in Hurricane Helene's path.
Yep.
And the damage was quite significant. And Baxter supplied approximately 60% of the IV solutions used in the United States. And, which is quite concerning. I think that concentration of any of the products that we need in one particular manufacturing plant or distribution center should be of concern to all of us, be it here in the United States or, even internationally.
Yeah, we've seen it happen with other
It's not the first
instances,
time.
So I think it's time that somebody addresses that.
Right. And the ASC Association, or ASCA, requested that a national public health emergency be declared that could help alleviate some of the problems that centers are currently facing. Now, we have heard that the situation is getting a little bit better, but that's as of our recording here on October 19th. So we'll see how that changes. Yeah. Sue, I think you had a couple notes right out of the ASCA's letter to the Department of Health and Human Services.
I just took some quotes out of there. I think it's, and we do want to mention again that ASCA is always advocating for the ASCs and definitely an important service. So one thing they had said is one of the critical services ASCs provide is colonoscopies, which allow for screening and prevention of colon cancer. ASCs in the U.S. annually perform approximately 1.3 million colonoscopies on fee-for-service Medicare beneficiaries alone, and it's critical that surgery centers avoid potential shutdowns that would curtail these necessary procedures. Surgery centers must run efficiently to remain viable and continue to provide savings to Medicare and needed care to its beneficiaries, especially since most ASCs operate as small businesses, with approximately 54% having only one or two operating rooms. And smaller ASCs already pay more for supplies since they lack the purchasing power of a hospital or a large health system. And we fear that IV fluid shortage would only drive up costs. In addition to declaring a national public health emergency, the U.S. Department of Health and Human Services should continue to work with and encourage the U.S. Food and Drug Administration to declare a shortage of sterile IV solutions in order to allow certain flexibilities not otherwise available to healthcare providers. In addition, we request that waivers be provided to extend the shelf life of sterile IV solutions that are beyond or nearing their expiration date.
And that's a very good point. Those we know that many of those expiration dates tend to be, based upon studies that were performed many years ago that might not be accurate or might be very conservative. And this has happened quite a number of times before, particularly in drug,
yes, we've seen it before in
situations.
drugs shortages where they can, the manufacturer can put that out. It's not something that we can just ignore the expiration date, but if the manufacturer is allowed to, they can pick a date that is still safe, but they have to set that.
Yeah, and so you actually bring up a very important point. Do not use expired medications unless that manufacturer has given you permission to do that or extended that life. And have documentation of that extension and keep that documentation with your drugs and in your records.
And if they do extend the expiration, that is only good while there is that shortage. If you are able to get, if the shortage resolves, you do have to dispose of those other ones.
Yeah, I mean, I've heard some stories of people saying, well, there's an emergency, so we should be able to do this. Well, again, you can only do that when you get permission.
Yeah.
Sue, I think we've been talking about OAS-CAHPS for years now, and I hope our listeners are not tired of us talking about it. I think I am slightly tired of talking about it, but we did have an opportunity to sit down with Lindsay Hanrahan, who has been on the podcast before. She's with Surgical Information Systems, and we had a kind of a wide-ranging discussion about how computers could be very helpful in making the transition to OAS-CAHPS much more smooth. And it also brings up the topic, and Lindsay and I tried to talk about this a little bit during this interview, about how important and where the future is with electronic medical records, because we know that the time is running out, really, for that transition, as our stakeholders are requiring more and more information that we can only gather from an electronic medical record. But OAS-CAHPS is a good example of how you almost have to have an electronic medical record or a lot of information in your computer system to be able to provide to the OAS-CAHPS provider, to be able to make this transition. So again, a reminder here that OAS-CAHPS will be implemented in January of 2025. You have to participate in order not to be penalized by Medicare if you are a Medicare provider. So let's take a short break, and when we come back, we're going to have this interview with Lindsay Hanrahan with SIS about OAS-CAHPS.
Surgical Information Systems is a proud sponsor of the ASC Podcast with John Goehle. Our award-winning software platform, SIS Complete, is the choice of over 1,000 ASCs. Why do so many surgery centers operate smart with SIS solutions and services? Because modern cloud-based software with modules for inventory, scheduling, revenue cycle management, clinical documentation, patient communications, and analytics, all on one platform, streamlines workflows and delivers data, including detailed case costing, that helps centers run smoothly and stay focused on what matters most: patient care. Efficient, comprehensive, easy to use. That's smart. And it's all backed by an industry leader who has focused on surgical software for over 28 years. To learn how Surgical Information Systems ASC software or revenue cycle services team can help, call us at 800-866-0656 or visit us online at sisfirst.com.
So I'm here with Lindsay Hanrahan with Surgical Information Systems. Lindsay, why don't you introduce your role at Surgical Information Systems?
Hi, John. Thanks so much for having me. I am Vice President of Product Management. I've been with SIS for many, many years, dating back to the SourceMed days. Have seen all of our products through lots of different regulatory changes and market and industry changes. So I really just in love with the ASC industry and love working with our customers. So my focus is mostly with our ASC software packages and specifically focusing on our data solutions and integrations also.
And for long-term listeners, right? And for long-term listeners of the podcast, Lindsay is not a newcomer to us. She's been with us before. I can't remember how long ago it was, but it's more than a year ago, right, Lindsay?
Yeah, a couple of years, I think. Yes.
Well, Lindsay, we've been discussing OAS-CAHPS quite a bit on the podcast. So OAS-CAHPS is a big topic of discussion right now on the message boards, and we're running out of time. And in our last episode, we talked to Kara Newberry with ASCA, and she kind of mentioned that only about a third of surgery centers have so far signed up for OAS-CAHPS, which, Lindsay, is starting to scare me, because obviously the deadline's coming. They have to be doing this on, starting January 1st. So why don't we start out by reintroducing OAS-CAHPS, talk about what it means and what we have to do in order to comply.
Sure. Yeah, sounds great. So as many of your listeners know, OAS-CAHPS was introduced as part of the CMS proposed rule way back in, I think it was 2016 or 15. And it's been available on a voluntary basis since that time. But as you said, time is up coming January 1st. It will be a requirement for any ASC who receives Medicare or is doing more than, I think it's about 240 cases a year that are paid by Medicare. And if they don't comply, then there would be a 2% penalty off of their Medicare reimbursement, which of course then could impact other payers
Right.
if their contracts are based off of the Medicare rate. So definitely important. I think the other notable part of it is just that the goal for CMS is that this data would be publicly reportable starting in 2016. So from a competitive standpoint, just making sure that your facility is participating, doing as well as possible, it gives you an opportunity to highlight the good work that your team is doing. And remain competitive with your peers.
Well, and you bring up a very good point, is that even if you're not required to do OAS-CAHPS because of either the 240 case limit, or you don't do any Medicare cases at all, I guess, then you still could have a reason to want to participate in it, because that lack of information might be sending the wrong message to the stakeholders that are looking at that data.
Yeah, I totally agree with that. I mean, I know that it does represent an additional, quote unquote, burden to the ASC, but, most ASCs are already doing some form of a patient sat survey. So really, it's just kind of transitioning over to a different method and, knowing the nuances of the program, of the survey. There are definitely things that your team will need to be aware of for compliance and to support compliance, making sure you're working with a CAHPS certified vendor, et cetera. But aside from that, facilities are already largely doing this, and it does give you an opportunity to highlight the good outcomes and good experiences that your patients are having. I mean, ASC is part of why I love this industry is really, we're like the little engine that could, we're always, every time a challenge is thrown up in front of the ASC industry, I just feel like, as an industry, the ASCs knock it out of the park and deliver awesome care at a better price, better outcomes. And I think this is just another area where ASCs will prove to have that result in the long run. But
we have a great message, and we want to get it out there. But to your point, surgery centers are already doing satisfaction surveys. It's one of the requirements of your CMS certification, certainly the accreditation. But it really, moving to an OAS-CAHPS really means a sea change in the way you're doing operations. Can you talk a little bit about that and the CMS vendors that are certified vendors?
Yes. So I believe there are about 16 CMS certified vendors today. At least one is no longer accepting additional ASCs just because their backlog of facilities to onboard is already full for the rest of the year. So another good reminder and a reason to if you haven't picked a vendor, to move forward with that as soon as you can. But it does represent a big change to your point. So a lot of times centers right now have a more abbreviated survey. This survey does go to about between 32 and 34 questions, depending on the mode. But a lot of them are really, really quick. So there are things like, demographic information about your facility, et cetera. And then at the end of the survey, there's an opportunity for a free text and then also for facilities to add their own questions. So as long as your vendor supports that, you do have the opportunity to add questions that are specific to things that maybe your facility has asked in the past or that you feel like you always get good feedback on. And then, of course, you can also continue to survey patients who, once you've met the threshold for the year, you can have a portion of your patients every month that are surveyed for just like a non-CAHPS patient SAT survey, and also patients that fall out of the eligibility criteria can also still receive a regular patient satisfaction survey if you decide to do that.
Yeah, that's a very good point. But you can't be sending a satisfaction survey with the same questions or similar questions to individuals that have been selected for survey purposes. Being a quality improvement guy, one of those things I'm passionate about. And I've mentioned this many times on the podcast. I'm concerned about our ability to connect our quality improvement program findings to these OAS-CAHPS surveys because, as you said, you can add questions to the survey, but they're going to be added on to 30 some odd questions that are already there. And by the time they get to those questions, we talked about this when we were prepping for this, how many people and what happens if they decide not to finish the survey because they realize that they're going to have to answer a lot of questions.
Right. Yes. Is my understanding from talking with some of the vendors is that as long as the patient has reached a certain number of answers that the survey does qualify, they don't have to complete all 32 or 34 questions. I apologize. I don't know the exact number, the percent that they have to get through. But if it is incomplete, there is a point at which it will count.
Yeah, and and again, my point has been I'm worried that the utility of the satisfaction survey using the OAS-CAHPS system is going to decline from where we are right now. It's nice to be able to change our surveys on a dime. Many of them are still paper, some of them are telephone calls, but it doesn't take much to be able to change those questions around so that we can fully we fulfill the requirements or the needs that we have as a quality improvement program to identify things that can be changed. So I do think I'm a bit concerned, about that. But to your point, you still, can do another survey. But think about this, now you'll be managing two surveys and the data coming out of two surveys. And let's face it, most of our directors of nursing and administrators out there, they barely have enough time to do what they just managing their staff, let alone dealing with all of these complexities that are being added to the quality improvement program.
Yeah, I mean, I think it's a really important thing for facilities to discuss with the vendor as they're going through the vendor selection process, just so that they can understand if they do plan to do additional surveys, what that would feel like for their team, for their leadership team and their quality leads. Will they have a different experience if they're managing, if they're doing an additional survey, or can it be streamlined into the same process so that they're not really having to have oversight of, CAHPS versus non-CAHPS? But to your point, John, totally valid that, I do think in the past, the flexibility of not having to conform to this very prescribed process in terms of the content, the timing, the administration of it, how facilities can talk with patients, even talk about it, et cetera. It's very different. One of the things that I've wondered about really is just the turnaround time, because I know historically facilities have really wanted to send the survey as quickly as possible upon discharge. Not immediately, but enough that the patient gets home, they get settled, they're feeling a little better, and then really to follow up and see if there's anything that could have gone better, so that they can get that feedback and act on it as quickly as possible. And with CAHPS, there is a delay in terms of when the surveys are allowed to be sent. So if you have a patient that was seen like the 5th of the month, they would be in the report for that month, but that month would not be sent to your vendor generally until the following month. So you're looking at, pretty much a matter of weeks instead of days for when the patient would receive these surveys, and then in turn, when your staff gets the feedback. So, just the feedback loop is much more elongated compared to what I think most facilities were doing previously.
That's a very good point. We in using the manual system that we have now with all of its, complexities, at least you're getting something hopefully within days from the patient. And here, as you said, this could be a long time. And I know, and again, it's going to come down to that free text section. In addition, that other valuable information that you're being given in a text format. And sometimes we find complaints, coming out, which we have to respond to very quickly. Maybe it's an anonymous complaint, but nonetheless, it's something that we have to act on from a quality improvement standpoint. The farther it is from the actual data service to the knowledge of this means, a lot less of an opportunity to respond properly to the patient, make them whole or whatever happened, or to change whatever system might not have been perfect based upon the feedback you're getting now. That's a very good point. When we're looking for a CAHPS vendor, what are some of the things that we want to be looking for? As you said, there's quite a number of vendors out there, but it's going to be difficult to call upon them. I'm sure right now the feedback I'm sure that right now they're not all getting back to you quickly because of the sheer number of surgery centers. Over 6,000 surgery centers that are looking to sign up for OAS-CAHPS right now. So what should be some of those first questions that we're asking these vendors?
Yeah, I've talked to a lot of them, and honestly, they all really seem very, eager. They've been pretty responsive, so I think that bodes well, hopefully, for facilities. I'm sure top of mind is, pricing. And of course, that's going to be a component of it. But for anybody learning about CAHPS, there are different modes that you can choose from. So in talking with some of our customers, it's just been interesting to hear their decision-making process. Makes total sense. They're considering things such as what's the mode of communication that's going to fit best for their patient population and for their case mix. So if they have a population that tends to be, more responsive to mail or phone call versus online, just making sure that, I think, number one, you're weeding out any vendors that cannot do the type of mode that you think will work best for your facility. And ASCA has a really good a grid online on their OAS-CAHPS page that just shows the different modes that each of the vendors are able to support. So that's a really good starting point just for understanding, who's certified, links to their websites and all of that, but also what the modes are. And then also just asking about things like their contract terms. So CMS does allow for facilities to change vendors periodically. I believe it's almost every quarter, if I remember correctly. But of course, vendors will probably want you to sign a contract for a longer term. Generally, it's, a year or more, but, you can always ask for flexibility with that, unless there's some real benefit to you as the facility for signing something longer term. But that's a good question to ask. I think given where we are with the timeline, one of the other really key things to talk about is their implementation backlog. Yeah. So, when can they, if you were to sign, in X amount of time, when realistically would you expect to be able to start submitting data, even if it's just as a test run, ideally to be able to get some feedback on, what kind of, working out any kinks, ideally getting some feedback sooner rather than later, although I think that window is starting to close as we get closer to the end of the year. And, I would also say, do they have experience working with ASCs? So a lot of these vendors have done other types of quality programs in other care settings, but not in ASC, of course. So some of them have, because they've been doing the voluntary support of, they've been accepting CAHPS on a voluntary basis, but some of them are in completely unrelated care settings, which can be fine. But I think there are nuances to ASCs and different considerations that, play into the workflow and the patient flow and training of your staff, et cetera. So I always feel like, if there are members of the leadership team at the company that have experience with ASCs, or it's a vendor that's just been in the space for a long time and really understands ASCs specifically, that's always great too. Some of the other considerations are just, staff training, support, what is their turnaround time? If you have a question or an issue, what are their service level agreements for getting back to you and making sure that your team has what they need to move forward? And then at the end of the month, what milestones do they have for when you should be submitting data? And then how do they go about getting any updates from you? So if you, for example, if a patient is in the report that you submit or that goes over to them automatically, if that patient is missing some pertinent data, like if it's they're missing a phone number, for example, then if it's a telephonic survey, of course, that's a problem. So what is the feedback loop? Like, how do they let your team know that that data is missing? And then what amount of time do you have to correct that and make sure that it gets added and send it over to them again? That kind of feeds into another topic about just kind of making sure you're collecting all of that proactively up front. Mm-hmm. But that's kind of different. Maybe we'll talk about that when we talk about the ASC software side a little bit more.
Well, let's go back to implementation just for a second, because here we are. We're recording this in the beginning of October. And of course, our listeners will be listening to it over the next couple months. My fear right now, just some of the feedback that we have from some of our clients, and I don't know what your feedback has been recently, is that we're running out of time. That the implementation is going to take a while. Testing to make sure everything's working well, making sure that your software, and we'll talk about that in a second, is able to transmit that data to the vendor. If you're not, and I don't mean to scare our audience, but they probably need to know this, is that if you haven't already started this process, finish listening to the podcast and then immediately start working on getting this moving, because as we mentioned earlier in this interview, it seems like about 2/3 of the places out there, surgery centers out there, have not yet signed up for this. Now, that's not to say that they're not already in the sign up phase, but I am worried that the time is running out. But to your point, you're going to have to transmit data to this vendor in an electronic format, and what is your software vendor? First of all, let's define software vendors from an ASC standpoint. But what type of information is a software vendor going to have to transmit to the OAS-CAHPS vendor electronically?
So a lot of it is data that facilities are already collecting, to be honest. It's mainly patient demographic and case data. So the important thing is making sure that along the course of your workflow, you're capturing, if your system has the ability to turn on configurations to be sure that certain fields are treated as required, so they can't be missed as you go through. So as an example, like an email address. If your software has the ability to turn on a feature flag so that field has to be collected during registration, that will help to later, when you're submitting that data, make sure that you have all of the data needed if you were doing on the online mode, as an example. But generally, once you get through the data collection process, again, there are a few things that are specific to CAHPS that I think facilities also need to just be on the lookout for and be sure that they know where they are in their application and also that their software has it. But as an example, there is also a no publicity flag. So if a patient specifically requested to opt out of the survey, your team would need to know where to indicate that in the application so that that patient does not get included in the feed that is sent to the OAS-CAHPS vendor. So, I think a good additional next step, as well as looking into immediately going to the ASCO website and looking at the list of certified vendors, is to call your ASC software vendor and be sure that you have access to all of the information they have about report readiness. Where is the report in their system that the facility can run and send? Is there an automated option available so that your team doesn't need to do that every month? So you just basically set it and forget it to send on a certain day of the month, and your data automatically goes out, and then an update goes out automatically on another milestone date with any changes needed. So that's a great question. Any of the configurations, hopefully vendors are putting together tip sheets for customers so that they can be as ready as possible. Also making sure that your ASC vendor has sent data and has experience working with the vendors that you're considering. Although there are about 16 of them, some are from our side, at least, we see a lot of the same vendor names pop up frequently. And they're not necessarily the largest ones. It seems to be that they're, I don't know, they've just emerged as the most popular for some reason.
For the ASC industry,
just make sure that your software is able to successfully send to vendors that you're considering. And see, they may even have a preferred partner or relationship that could benefit you, whether that's in the form of pricing incentive, or even just like streamlined onboarding or streamlined troubleshooting and communication, just so that as your team adjusts to data collection for CAHPS and data submission, you're not having to go between vendors to get answers, if at all possible. So all of those are things that I think are good and really valid to ask your ASC software partner.
And let's talk about that for a second. Is that ASC software vendors? That obviously there's a few software packages out there, SIS included, that make up the majority of the vendors that serve the market, the ASC market. That provides revenue cycle, billing, et cetera, as well as inventory and purchasing support, as well as quality improvement, et cetera. But there's also a lot of vendors out there that are providing software to ASCs that really don't specialize in ASCs and might not even be aware of the regulation that's coming up that requires them to be able to the organization to be able to submit. The organization to be able to participate in the OAS-CAHPS program. So, so that's one of my concerns, and I know you and I talked about this before we started recording. Is you need to make sure that your vendor is able to support OAS-CAHPS, is knowledgeable about OAS-CAHPS, and yet another reason why you need to be looking at vendors when you're choosing your software. You need to be looking at vendors that are in the ASC space and specialize in ASC software.
Yes, I mean, clearly I'm biased in this comment, but I would completely agree with that. I mean, we've had most of our products ready to support CAHPS for several years now because of the importance to ASCs, and knowing that every year there's a chance that it could be, it could end up in the final rule, and we wanted to be sure we were ready. We do also have clients who were participating on a voluntary basis, and have been for a while now. So they're fortunate at this point. But I have heard just anecdotally from some of the CAHPS vendors that we're working with, that when they have worked with some packages that are not really, ASC specific, that it's been tricky. So, not getting into specifics or anything, but it's been kind of an unsolicited comment that's come up in conversations. And generally the vendors are just very grateful to be talking to people who, are familiar with it and want to make the process as easy as possible for ASCs, and also, frankly, for vendors, because the easier it is for the vendor, then the easier it is going to be to get more and more facilities live. So that's part of our focus has been let's make sure that from an application standpoint, we're doing things as, kind of vanilla as possible, so that we're making it, if a vendor has a report coming from one of our clients, it's as similar as possible to a report they get regardless of which of our products they're using. Because again, just on a, when you look at that at scale, it really does have the potential to make a difference and help those vendors go more quickly, and reach more facilities before the timeline is up.
Yeah, and I'm most concerned about those organizations that might be tied very closely to a practice and have opted to use the practice software for their ASC billing, because I think many of those packages out there are going to have a hard time transitioning, mainly because obviously those practices don't have anything close to OAS-CAHPS, the Medicare quality reporting requirements that we have from CMS.
Yeah, and especially with some of the new quality measures that are proposed for next year, which again, who knows where those will end up as far as the final rule is concerned. But some of those are really, a couple of them are very interesting.
Yeah.
Let's say, but again, to your point, I think really critical that you're working with a partner who closely follows any of these new potential measures, so that you can be assured that your product is going to be ready within whatever implementation timeline ends up being included in the final rule. So yeah.
So a thought comes to mind here. Do you think, based upon these changes to our satisfaction surveys, do you think we're going to have to do some training of our staff on how to talk to patients about the satisfaction survey that they're likely to get?
Yeah, I think it's a really good point. Definitely something that facilities should talk with their vendors about, to understand what they include as far as staff training, and also to be sure that the facility leadership understands what the can and cannots are for discussing the survey with patients. There are CMS requirements that specify how the facility staff, what they can and cannot say to a patient. So definitely important that a patient knows that they may receive a survey, so that if they receive it, they recognize that this is the survey that was mentioned. But there's very specific terminology about what the facility team can and cannot say. Kind of more broadly, though, I think that when it is a good opportunity for the facility to look at, become familiar with the questions that are in the survey itself. And specifically what it's looking at. I mean, they're really all things that facilities are already doing, making sure that there's good communication with the patient, that they're receiving discharge instructions, they know what to expect, et cetera. There are very specific questions to each phase of care, basically. And I do think that it may make sense to look at, especially, of course, my mind is always looking at things more from a product perspective. So, but, look at, what do you have in your center today that could help you be successful in these things? So how do you make sure that these things are happening all the time? All of these communication touch points are happening consistently with every patient, and that if something is missed, God forbid, that your facility team is able to identify that quickly and catch it and get on it. So a lot of these are things that, again, I feel like facilities are doing. They generally do a really good job at it, but it's a matter of, do you have your products set up in a way where it's really built to be embedded into your process, so that a human isn't having to think every single time, oh, did I include this document or that document? There are a lot of tools available in ASC packages to allow that communication to happen automatically, and using the patient or their family member's preferred mode of contact. So I know for me, I get something in the mail and there's no way I'm, everything in my life pretty much at this point is digital. But then, if I receive something in the mail and that's the thing that I'm then surveyed on later, I probably wouldn't, I may not even be aware that I had received it. So, again, just being mindful of within your workflow, making sure that you are, really bringing your team's attention to those touch points, and that your team is aware that these are points that they'll be measured on.
So, Lindsay, this has been great, but it kind of brings up a broader topic, doesn't it? And that is, we're running out of time to move toward electronic everything when it comes to information. We know based upon some studies that perhaps even half of the surgery centers are still on paper for medical records. What are your thoughts on this? Are we indeed running out of time? What are the ramifications of not moving to EMR? How can those poor facilities who are dedicated to their paper records going to fare in the information-heavy future?
Yeah, I think it's a great point. And, granted, I've been in product development my whole career, in healthcare IT my whole career. So I realize I probably see things through a slightly different lens. But I really do think that the industry at large, there are so many influences at this point that are pointing toward the need to adopt. So, whether it is a quality measure for CMS or participation in a health information exchange, those are starting to pop up and become required in certain states. So, again, obviously, if you don't have any of your data electronically, as far as clinical information goes, it puts you in a tough spot in terms of being able to comply with an HIE requirement in the event that one emerges in your state. Several states are introducing them, and they're just not required yet, but several do actually have them required. So, in addition to just regulatory requirements and the need to share data with other surrounding entities that are in your ecosystem, whether it's a referring provider or some other entity that you need to your transcription company or another company that you work with. Having all of that information electronically just gives you so many more options for just being smarter with your workflow and identifying opportunities to prevent things such as, HIPAA incidents, for example. John, you and I were talking previously about how just paper's the worst.
Yeah.
And so, it's sitting around and it can be a completely passive there can be a completely passive incident where, a face sheet is left out or just somebody gets the wrong statement or something like that. I mean, truly, it is a much more error-prone workflow compared to electronic workflows. So I think just, from a risk reduction standpoint, it's a big improvement. And the most important thing, I think, is just, ASCs truly do provide really amazing care to patients. Yeah. At a better value, better outcomes. And part of the way that they've succeeded in doing that is just being smart with resources. And, once you have an ASC specific application in place, it really does, it is an adjustment making the transition. But once your facility is on it, there are really so many efficiencies that can be gained that then give your staff time back to devote to patient care and making sure that your facility is running as best as possible.
Yeah, and I think our stakeholders are going to demand a lot more information in the future. We're already seeing it with Medicare and CMS in the form of OAS-CAHPS as well as the other Medicare quality reporting measures. But our insurance companies, our state governments, perhaps other parts of the federal government, as well as the employer groups that ultimately pay for that insurance, are all looking for quality information from us. And the days of being able to provide that on paper are quickly disappearing. So I think a big message we have to get across right now is that if you're not already, in addition to looking into OAS-CAHPS, if you're not already looking into a future EMR system, you should be doing that. And of course, as you and I have talked about, be very careful about those systems. Make sure that they really have been designed for the ASC environment, because these reporting requirements are not going away.
They're not. And I also, that one other point too is, just the old adage that, you can't improve what you don't measure.
Yeah.
So, measuring anything in a paper world is just, not going to be possible. And whether it's for quality measures or, a clinical measure, or it's for, contract renegotiations where you need to be able to demonstrate what your cases are costing you, as they're actually being performed, so that you can go to, your payers and renegotiate for better rates and all of that. I mean, really, just there are so many reasons where, having data within the system that you can harvest and do something with and make smart decisions for your facility, using it. It's just the use cases for it are really pretty endless. But I would 100% agree, whether it's with CIS or a different vendor who knows the ASC space well. There are a lot of nuances to the ASC space, and so I definitely agree with that bit of advice that going with a vendor that knows it well is very critical to your success.
And I guess one thing I'll end on is keep in mind your competitors out there. We're a much more competitive environment, and if you can't show that your quality is as good as and hopefully better than your competitors, you're going to be at a competitive disadvantage. So that data is going to be critical to help you in making those decisions.
Yep, 100%.
Lindsay, this has been a pleasure. Thank you so much for your valuable information here, and I'm sure we'll have you back again soon.
Thanks so much for having me, John. Great to talk with you.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
Our ASC-Central Virtual Director of Nursing Bootcamp starts on October 22nd through the 25th. That's the virtual conference portion of it. There is also mentoring involved, as we talked about earlier. For more information about it, visit ASC-Central.com.
The Becker's ASC 30th Annual Meeting, the Business and Operations of ASCs, is October 30th through November 2nd in Chicago, Illinois at the Hyatt Regency.
The Washington Ambulatory Surgery Association's 2024 Annual Education Conference and Trade Show will be November 7th and the 8th at the Tulalip Resort and Spa in Tulalip, Washington. I'll be speaking about accreditation and provide an update on accreditation trends, and we'll also be recording a special episode from there.
And the 2024 Multi-State Conference is November 14th through the 16th, 2024, presented virtually. We'll provide a link in our show notes for more information.
And yet another first for ASC Central is the ASC Life Safety and Environment of Care Conference is going to be November 12th, 2024. Again, presented virtually. It is a full-day walkthrough of the life safety and environment of care requirements for ambulatory surgery centers. And it's designed for staff responsible for the life safety and environment of care documentation, ASC administrators and ASC Directors of Nursing. It's a great full-day conference. For more information, visit ASC-Central.com.
And ASCA's 2025 Conference and Expo is April 30th through May 3rd, 2025 at the Gaylord Rockies Resort and Convention Center in Denver, Colorado.
And don't forget, on-demand versions of the ASC Director of Nursing, ASC Administrators Bootcamp, and our Business Office Managers Bootcamp are available on our sister website, asc-central.com. And we do want to remind everyone to become a patron member of the podcast, available on asc-central.com. This exclusive membership website is a one-stop shop for all things ASC regulatory and accreditation, compliance, operations, and financial management. And it's perfect for busy administrators, nurse managers, and business office managers. With your membership, you get access to regular, usually weekly Zoom sessions where you can connect with other patron members and our podcast team. And you also gain access to a treasure trove of resources, including some of our virtual conferences, like the Credentialing Conference and the Conditions for Coverage Conference. Plus, we provide example policies, procedures, sample forms, and our fire and disaster drill kits. Your membership helps to defray the cost of running the podcast by covering the costs like research, travel, equipment, and production. For more information, please visit asc-central.com. And thank you for joining us on this episode of the ASC Podcast with John Goehle. And if you found the episode informative, we encourage you to share it with your friends and colleagues in the ASC industry. And don't forget to hit that subscribe button so that you never miss an episode. And we'd love any feedback about our episode or ideas for future episodes by sending us an email at comments@ascpodcast.com. We'd like to give a special thank you to our great team here who make this podcast possible, our sound editor, Susan Cronkite, our executive producer, John Goehle, and our dedicated research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Alex Borneman, Zach Kelleritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Fode, Donna Macchio, and Christina Norman. We couldn't do it without them. Our music is provided by Media Sushi and Mike Nolan. The ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thanks for listening.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.